Good evening, welcome. Can you hear me all right at the back?
Yeah.
Perfect. Those of you sitting near the back might want to consider moving near the front, because Norman, our speaker later, has brought all sorts of things with him, which you won't necessarily be able to see. It's your choice. So good evening and welcome. I'm Donald MacArthur, President of MedChi for 25-26 session. Just a couple of pictures on the introductory slide here. MedChi was founded in 1828, and one of its functions was to put together meetings to get doctors together. Another was as a repository of medical books, and it still has a lot of those medical books. And some of us went to the archive that the University of Nottingham has in the spring of last year and saw some of these wonderful books. I think the oldest one there is from 1538 and is a copy of a Galen work, which is great. One of the most readable and interesting ones I found was this Ambrose Parry 1691 edition of The Anatomy of Man, and actually it's really quite accurate. When you look at the bits of the body I'm interested in, like the brain ventricles and the blood vessels, for 1691 it's amazing what they knew and how well they got it mapped out. Some of our early books and some of our early meetings were held in the Bromley House Library in the centre of town in Angel Row, which is still there. And on the 14th of February, MedChi's arranged for a trip to Bromley House Library, and I think up to 15 people are going to be able to go to that. So if you're interested in going to see the Bromley House Library, get in touch through the admin team, and there's still spaces to come to that. Hopefully if I press that button, things will move on. Yes, so apologies for absence. I haven't had any specifically to this meeting, but I did want to mention that Leslie Baker, a former president of MedChi and a significant figure in Nottingham medicine and obstetrics and gynecology, sadly died in the last couple of weeks. And Dr. Joe Jones is here and knew Leslie Baker well and is going to just say a couple of words about the arrangements for her funeral. So Joe, please come down, or shout from there.
Saturday, February the 7th at 2 p.m. and I'll be finding out the exact details and I'll pass them on for circulation.
Okay, thank you very much. Previous meetings, if there are meetings you wish you'd been at, if you look at the programme, you can access all of these. In the old days we used to have the minutes of the meeting, but in the modern era the meetings are recorded, and you can go to the YouTube channel. And if you have a look on that, the important bit is to go to MedChi, and then where it says playlists there, then you'll see each of the presidents by year, and all of the lectures from most of the last few years are there, and can be seen. There's a couple of years during COVID when we started to go hybrid, digital and so on, where the lectures sadly aren't there. But going back to the last 10, 15 years, most of the lectures that have been given to MedChi are all there, so you can enjoy them over again if you want to see them. Just looking back at the ones this year, Nick Maynard, who gave the lecture about life in Gaza in the hospitals there in December, which was quite a thing to see. That's had about 200 views so far, so people are looking at these, and feel free to go and have a look. So upcoming social events, we've got an origami workshop on the 24th of January with David Bogod. If you haven't been before, think about it. He's pretty good at that, and it's pretty enjoyable. The Burns Supper on the 30th of January, Mary and I will be your hosts again for whiskey, Scottish food, dancing, a couple of speeches. It's all very informal, it's a lot of fun. We can have up to about 75 people at that before it gets too crazy. So feel free to find out more about that and come along. The details are on the website. There's also forms up in the room up there for how to sign up to come to that. You can come as a couple or you can come as a bigger group. It's all one big table, so it's very sociable. The other social events that are upcoming, the Medical Staff Committee have invited us to join them at their MSc dinner, which is on a Thursday night, the 12th of February. I'll be going, a few other council members are going, but if you're keen to come to that, then please do come along. You can either enrol directly through the Medical Staff Committee, or you can let us know through MedChi that you want to come and sit at a table with MedChi people. And then far more importantly, in May, about 4 months from now, we're organising a ball. So please put that date in your diaries and get ready to think about who you want to come to that ball with. We'll have a string quartet, we'll have a casino, we'll have a live band, the Spinal Cords, who I can vouch for the level of talent there, it's magnificent. We'll have some racing simulators. We always used to have dodgems in the old days, but that was slightly, there were risks with that, involving mud and neck injuries and so on. So we're going to have Formula One racing simulators instead. So we'll have 4 racing simulators set up side by side, and you can race to your heart's content all night and try and get the best lap time you want. And it doesn't matter how much you've drunk, you can still get on the racing simulator, whereas the dodgems wouldn't necessarily have agreed with that. And obviously there'll be dancing and decent food and welcome drinks included, and we anticipate the ticket price to be £90, so we hope to get a few hundred people to that if we can. So on to our President's charity. All of these charity events are raising money for doctors in distress who do great work supporting doctors who are struggling for one reason or another or in difficulty, and that's the Just Giving link for that.
Having just been on the Doctors in Distress, you can add it to your wallet. If you come regularly here and you think, oh yeah, that was excellent, I'm going to actively donate, you just have it in your wallet, you just need to click on it.
Thanks, Hatchet. Next lecture in a month's time, we've got Dr. Jonathan, or Professor Jonathan Corn, I beg his pardon, who has more titles than you can shake a stick at there, but essentially is, most importantly, the regional postgraduate dean for the whole of the Midlands now, and knows a thing or two about medical education at the moment, and a lot of the fairly radical things that are going on at the moment with the medical training review, and is going to talk about where he sees his vision for where medical training is going and should be going. So that's on Wednesday the 25th of February. We'll also have 2 of our students, we give out 4 or 5 elective bursaries every year, and 2 of our students who went on elective last year are coming to give their reports online that night. So we've got a report from Tanzania and a report from Peru about medical electives that night as well, on the 25th of February. So tonight's lecture, as many of you will have noticed, is called the Tony Mitchell Memorial Lecture. And that's a name I knew as someone who's been involved in MedChi for a long time, but I didn't really know that much about him, and I thought I really ought to find out a bit more about him. So I've been researching that for the last couple of days, and it's been very interesting. So John Richard Anthony Mitchell was a Yorkshireman born in Shipley in 1928, educated in Morecambe Grammar School, and he went to Manchester University where he got a first in physiology, and then carried on to complete a medical degree, and he was a very, very high-flying student who people knew would do well. He married his wife Muriel in 1954 and had 2 girls and 2 boys, and he then did national service, which was at the time the thing to do. In 1955 to 57 he was in the Royal Army Medical Corps. From there he went to Oxford, where he worked in cardiology and academic cardiology. He was a registrar and then an MRC research fellow, and did an MD, and he worked for the great physician Sir George Pickering, who was a Regius Professor of Medicine at Oxford at that time, who was a great hypertension expert. He moved to Nottingham in the late 1960s after getting his MD. He got a gold medal for his MD thesis, of course, and he moved to Nottingham in the late 60s, and that at the time was a little bit of an academic backwater, and the first thing he did was start to establish more of an academic department of cardiology and medicine in the old General Hospital, and in preparation for the development of what was the first new medical school in the UK for a very long time, which was the new University of Nottingham Medical School. So that was founded in 1968, and at the age of 40 he was the first professor there, the foundation professor of medicine at the medical school. And he shaped really the way the medical school developed, and the development and design and commissioning of Queen's Medical Centre, which opened in the late 70s, as you know. That started to open in 1977, but I think the first patient went in 1978, and they were still finishing it in the 1980s. And the hallmark, his vision for the medical school was an interdependence of research, teaching and service, those 3 things together. His own academic focus was on what was going on in coronary arteries, platelets, thrombosis, infarcts, trying to understand how those things all linked up. Later in his life he became interested in epidemiology, trials and stroke, but above his interest in cardiology and academic medicine he was also very much a general physician throughout that. And in 1990 he was given the Moxon Medal by the College of Physicians, which is a triennial medal that's awarded pretty infrequently. There have been 1 or 2 other Nottingham people get that, but that's awarded for observation and research in clinical medicine. He was, sounds like a real character, I think, sceptical of accepted dogma, would never take anything on trust when people told me, wanted to know for himself what the evidence for it was. He demanded to see the trial evidence, the proof. Someone once called him the abominable no man, because he didn't believe anything until he saw the evidence, and I think that's a great thought. His BMJ obituary, which was written, I think, by John Hampton, one of his colleagues in cardiology, makes excellent reading. You can find it quite easily online. These are some quotes from that. He describes him as a splendid raconteur. Probably because of his national service, he said he had a cheerful antipathy to authority, so he didn't really care what people told him. He had his own views and he was prepared to defend them, and apparently could be absolutely devastating in a committee if he found himself faced with someone who he thought was not making sense. Above all, you see descriptions of him as a magnificent teacher of students and someone who was committed to education, and also that he took immense trouble with each patient, so the focus was on the patient and not just the teaching. And in his last year of clinical practice, he was Medchi president in 1989 to 1990. So he had been standing here 35 years ago wearing this medal in this lecture theatre, which is an interesting thought. The obituary says quite openly he was getting a bit fed up with the way some of the NHS reforms were going in 1990, and also some of the winds that were blowing through the universities, and he felt quite glad to say, I'm going to see the back of this, and leave. And he retired relatively early at 62, saying he was going to spend more time with his family, although sadly died unexpectedly within 6 months of that on a camping holiday in Cornwall. So he didn't, and sadly, have the long retirement that we would have hoped. There's a wonderful bust of him in the medical school, which I went to see today. It's just outside the library. He's got the same inscription on it as Sir Christopher Wren has at St Paul's Cathedral. Si monumentum requiris circumspice. So if you look for my monument, look around you. And that's absolutely appropriate. If you go and stand outside the medical library and look around the building, that is very much his monument. He's also obviously remembered every year by us with the Tony Mitchell Lecture. And we also have a Tony Mitchell Prize that is given to the highest performing student in the final year each year. So I'm delighted to say tonight we have Emma Buddle, who is the highest performing student in final year this year, coming to get her prize. And I'm even more delighted to say that Tony's eldest daughter, Anne Mitchell, is here to present the medal to her. So Anne, if you want to come up, and Emma, if you want to come up. So that's her medal. It comes with some spending money as well. Emma will be delighted to see. So we might just take a picture of this. So yeah. Let me take one from here, and you can take one from. So smile, ladies. Fantastic. And we'll take one a bit further afield as well. So Emma's working in Yorkshire and is from Yorkshire. So Tony Mitchell, I'm sure, would be absolutely delighted. Okay. Thank you very much. So, without much further ado, on to tonight's talk, which is the Tony Mitchell Memorial Lecture for this year, which is being given by my colleague from Interventional Radiology, Dr. Norman McConachie. I'm really, really pleased he's able to come and tell us what he's been up to in the last 30 or 40 years, which has, absolutely revolutionised life for us as neurosurgeons. When I came into neurosurgery, one of the biggest asks we might have was to clip an aneurysm or 2 aneurysms at night or over a weekend. Terry Hope sitting at the front here remembering those glory days when you saw it and you thought, oh dear, there goes the rest of my day or the rest of my night. And in my time in practice here in Nottingham, that's really all but disappeared. Almost all aneurysms are coilable in the hands of Dr. Jasper and Dr. McConachie, the people we've had here in Nottingham. So I'm absolutely delighted that he's here to tell us about developments in interventional radiology over the last 30 odd years. So you just press that one there, Norman, for forward.
Right, thank you, Donald. It's a pleasure to be here and an honour to do the Tony Mitchell Memorial Lecture. I'm conscious that many of you may not know what interventional neuroradiologist does, or you may not have even heard of interventional neuroradiology. So I'm delighted to have this opportunity to shed a bit of light on our small subspecialty. So what I hope to be able to tell you tonight is how it all started, talk about the evolution of some of the kit that we use, how it works, some of the research behind the processes, interventional neuroradiology as a career, and maybe a few pointers to what the future might hold for us. A little refresher on aneurysms. Terry, pay attention. There's an intracranial aneurysm is, of course, a weakness in the wall of one of the arteries in the brain, which forms a little bulge or blister. Most are small, don't cause any symptoms. People who have them mostly die in their old age of something else. But many are discovered incidentally, more and more as CT and MRI scans are so common for other reasons. There's an over 5% prevalence in the adult population, so if you're looking around, there's probably 2 or 3 of you with an aneurysm. And you know, most of the time, that's okay. Most of them don't need to be treated. But the main risk, of course, is that it might bleed and into the substance of the brain itself or into the fluid around it, causing a subarachnoid hemorrhage. And that, of course, is a life-threatening emergency. Over 1/3 of patients will die, and of the survivors, about half of them will have a range of disability. Of course, these were traditionally treated with craniotomy and clipping, starting in 1937 with Walter Dandy. Things improved in the 60s and 70s with the introduction of the operating microscope. And clipping is still done today, but its application is probably limited in most of the UK centres to a few anterior circulation aneurysms, so the branches of the internal carotid artery. And it's a pretty major operation. I mean, if you asked a patient, which of these procedures would you prefer to have done for your aneurysm, obviously most would choose the minimally invasive one, with the caveat, of course, that the risks are similar and the efficacy of the treatment is similar. Everything we do is really an extension of angiography, and that started almost exactly 100 years ago with this bloke, Antonio Egas Moniz, who was a Portuguese neurologist, and he did the first cerebral angiograms by doing direct stick of the carotid artery and injecting a contrast agent. Initially, he used lithium and strontium bromide, both pretty toxic, and he killed at least one of his patients just from using that contrast medium. He switched to using sodium iodide, and that seemed to be a bit safer, but still not recommended. He was a bit of a polymath, actually. He went into politics later. He had a big art collection, and he received the Nobel Prize for his work with prefrontal leucotomy, lobotomies. Angiography came on in the 50s with the introduction of the Seldinger technique, or the modified Seldinger technique, which involves putting a needle into the artery, passing a wire through that, using that wire to guide a catheter into the artery, and then pass that up into the circulation. And once it's in the cerebral circulation, we inject an iodinated contrast, which shows up as a shadow on the X-rays. The equipment that we use to visualize the angiogram has changed enormously in 100 years. Moniz may well have used something that looked similar to the one in the bottom left-hand corner. And of course, he'll have only taken one picture, but in the 50s and 60s, we were able to take a lot more pictures in rapid sequence and follow the bolus of contrast through the circulation. A whole series of different catheter types were available in the 70s, and then in the 80s, the development of digital subtraction angiographies, which took the bone and the soft tissues out of the picture and just left the contrast medium within the arteries, so you can get a much clearer picture of the vascular network. And this is what we've got now in the bottom right-hand corner, 2 of these, in fact, biplane angio equipment at QMC, each costing about £1.5 million. And these are biplane machines, so we can see the brain or the cerebral circulation in two directions at the same time. And it gives, fabulous pictures. Something's mangled my images, but it gives when we spin the machine around the patient's head and take a rapid sequence of images as it does that, we can build up a 3D image of the cerebral arteries and develop surface rendered images and manipulate those to get the best profile of the cerebral pathology with which we can then go on and treat. And with a similar sort of action, the machine can also give us CT scans on the table during the procedure at the same time. Whereas in the early days, we used to, during long procedures, give quite a high dose of X-rays to the patients, and it wasn't uncommon for them to have some hair loss afterwards. It's now extremely rare. The dosage that we give them is much less. Hand in hand with the development of X-ray equipment came the interventional kit. I've laid out some here, and you're very welcome to come down and play with it afterwards. And probably, most notably, it started with these guys in Russia. The one on the right is Fedor Sebrenenko, who's a Moscow neurosurgeon, who reportedly, after watching children in Red Square with helium red balloons, thought, oh, well, I might float a balloon into the bloodstream of the cerebral arteries and use that to block off pathological vessels. He and a colleague in Kiev called Viktor Sheglov developed detachable latex balloons, which they did float into the cerebral circulation and then push into an aneurysm and then inflate the balloon to fill the space in the aneurysm. And in 1974, they described over 300 patients that they treated this way. I think it's fair to say that the scientific rigor with which they operated and the transparency was not perhaps what it is these days, but nonetheless it stimulated a lot of interest in how you could endovascularly treat this pathology. Gerard Debrun, who, as he sounds, was French, visited Kiev and brought detachable latex balloons back to the West, and it went through various iterations, but one of them involved, I think one person in the room may remember doing this. You had to tie the balloon onto the end of a microcatheter yourself, and then obviously sterilize it and then push it into the brain. And the idea of this, you just partially inflate it so it was carried by the bloodstream to the area of pathology. Thankfully, in the 80s, somebody started making ones with an integral valve through the company called ITC. And most interventional neuroradiologists cut their teeth doing two procedures, one of which was vessel sacrifice. If there was an artery bearing an aneurysm, then you just block it off with these balloons. And the other one was direct carotocavernous fistulas. This is a patient with a direct CCF, which is a hole in the carotid artery which empties arterial high flow, high pressure blood into the cavernous sinus behind the eye. And of course the veins aren't designed to carry high pressure, high flow blood, and that pressure is transmitted forwards in the ophthalmic veins, and it causes or can cause severe proptosis, injection of the eye, exposure of the cornea, ulceration. You can lose vision, you can lose the eye in severe cases. And it's mostly caused either by trauma, worldwide that's the commonest cause, skull base fracture tearing the carotid artery, or an aneurysm, a cavernous aneurysm rupturing into the cavernous sinus. So I've unashamedly stolen this from the historical literature. The pictures in the bottom right-hand corner, this is the carotid artery, side-on view of the carotid artery carrying blood. Usually it carries it to the brain, but there's not much getting through because all of the blood is emptying into the cavernous sinus, and then all that pressure is being transmitted forward towards the eye. So this person's passed one balloon and then another one. Now you can just see the catheters here up into the carotid artery, and then allowed the predominant flow of blood through into the cavernous sinus to carry the balloon through, inflated the balloon, and used that to block off the hole. And this is the angiogram afterwards, so there's no filling of the cavernous sinus, and the brain is now getting its full supply of blood. But balloons weren't a great treatment for aneurysms, and so a company called Target Therapeutics in America developed a series of microcatheters similar to the ones on the table, microcatheters and microwires, so you could steer a catheter to where you wanted it to go rather than relying on the blood to carry it there. And it allowed reliable access to the circle of Willis. For anyone who can't remember their anatomy, a circle of Willis is a little internal bypass, if you like, at the base of the brain, formed by the internal carotid arteries on both sides, the anterior cerebral arteries, the anterior communicating artery, top of the basilar, posterior cerebral arteries, and the posterior communicating arteries. So a little circle which, if you lose one of these arteries, then usually the others will be able to feed into that territory and keep things going. And of course, most aneurysms occur around the circle of Willis. And these new catheters allowed placement of pushable fibred microcoils into the brain arteries and occasionally into aneurysms. But still, we didn't have a very satisfactory treatment for aneurysms until this bloke came along. The one in the middle, we are such a fun group in INR. But the one in the middle with a slinky around his neck is Guido Guglielmi, who was an Italian neurosurgeon who, motivated by the death of his father from a ruptured intracranial aneurysm, experimented with electrothrombosis, trying to induce thrombosis in the aneurysms from within. But annoyingly at the time, the coil that he used quite often fell off electrolytically. But after a while he realized this actually might be quite a good thing, and partnered with the engineers in Target Therapeutics in LA to develop a electrolytically detachable platinum coil. In 1990, while he was working in LA, a woman on holiday in LA was struck by a tennis ball, and that induced her cavernous aneurysm to rupture and cause a direct corticocavernous fistula. They tried the usual treatment, which was detachable balloons, but without success. So Guglielmi inserted some of his platinum coil and detached it with this little blue box. He was really disappointed because it didn't seem to work. The CCF was still there at the end of the procedure. So the following day they thought, well, we're going to have to go back in and try with a balloon. But when they did, they were delighted to find that the CCF had closed. And that was the birth, really, coil, which very rapidly became widely available in Europe, and in 1995 was approved by the FDA for aneurysm treatment. And really, that's when there was an explosion of activity in treating aneurysms endovascularly. Now, this is we've had a little trouble with a media clip, so we're just going to run this. do look at the person in the background with a full head of hair, because that was me. This was quite noteworthy at the time. No? Got a lot of feedback in there. Okay, don't worry about it. No? All right. It's a shame, because I was going to show Tim being interviewed by Tim Jaspin, who's in the audience, being interviewed by the local press. Nonetheless, it was quite noteworthy at the time. In 1995, this was, you know, on the local news that we could stick coils in people's aneurysms. And at the end of the clip, it was noted that we were about to join in a trial. Now, because we were such a small group at the time, even internationally, there weren't very many interventional neuroradiologists treating aneurysms. And so it was really important to get together, and international meetings became the place where you keep up to date with the very rapidly developing technology, share cases, and gain experience. I'm very pleased to say that the most important meeting to attend was the ABC WIN, which originally started in America, but in about 1982 or 3, I think, moved to France. God bless the French. And because they had a large part to play in the early development of our specialty. And they decided that the best place to have it would be Val d'Isère in the middle of January. And guess where I'm going next week? So it's still running. It's still a really good meeting. Anyway, I've highlighted... Oh, or have I? Oh, let's go back. So there is a chap hiding at the back there with a questionable taste in jumpers, who was a young interventional neuroradiologist from Oxford called Andy Molyneux. And this is me and Andy and Nick Higgins from Cambridge at a more recent Val d'Isère meeting. And Andy was troubled, he wasn't the only one, but Andy was particularly troubled by the INR culture, which is kind of maverick and macho and based on expert opinion rather than quality evidence. There was a poor appreciation amongst the group of the shortcomings of case series and bias in studies, uncertainty, statistical methods. And there was definitely the case that operators were overly keen to pioneer new techniques and use unproven devices just to kind of show off, I think. Many of them were involved in startup medtech companies and had their fingers in pies. And although maybe not to the same extent as Sermonenko or Monet's, there was definitely an element of experimenting on humans, which was of questionable ethical basis. So Andy was the main driving force, Andy Molyneux, behind the ISAT study, the International Subarachnoid Aneurysm Trial, which was an international multi-center prospective randomized clinical study comparing clipping of aneurysms to coiling of aneurysms, ruptured aneurysms. Things really got going in 1997. We started randomizing patients, and the results were published in 2002. I draw your attention to the final page, which shows... Oh, how do I go back? Which shows the participating centres in ranking order of the number of patients who were randomised in each centre. And top of the league, yay, was Nottingham, led batting for the INR team was Tim Jaspin, Norman McConachie and Rob Lentle. And for the surgeons, Barry White and Nick Phillips, and Sharon Stevenson was our research nurse. And the results, well, 24% of patients undergoing coiling were dead or dependent at 1 year, compared to 31% of patients who had neurosurgical clipping. So an absolute risk reduction of 7% and a relative risk reduction of 23%. Conclusion, therefore, was that disability-free survival at 1 year was significantly better with endovascular coiling. And really overnight, certainly in the UK, we went from treating maybe 50% of aneurysms to 85, 90% of aneurysms. And today it's more like 95% plus. It was a bit slower in the USA for financial reasons mostly, and in Japan and Finland, which had their own peculiarities with regard to aneurysms in their population. Whereas Tim and I, we would be really pleased to have 50 or 60 different coils on our shelf. I've just taken a picture of a couple of our trolleys. We've got 4 of these, and we've got 500 or 600 coils now of various sizes, shapes, lengths, you know, coatings, some which expand once you put them in the aneurysm. So an enormous explosion in development of coils by the companies. Thank you, very well done. And the idea is that you pack the aneurysm with as much platinum as you can safely. And we aim for getting about a 20 to 30% packing density with platinum. The rest of the occlusion of the aneurysm is made up by thrombus. And once that thrombus becomes, so fibroblasts grow into that thrombus, it becomes organized, turns into granulation tissue, so that after a few weeks you're left with a little ball of metal and scar tissue where the aneurysm used to be. So this is, sorry, come back. So this is, this is the one catheter, in fact, 2 catheters coming up, delivering coils simultaneously into this aneurysm. And at the end result, you can just see a shadow where the aneurysm used to be. We still had problems, though, with wide-necked aneurysms with big entrances, because it was very difficult to get a real good seal at the base of the aneurysm, and those aneurysms tended to recur after a period. So various techniques were introduced, one by Jacques Moret in '97, describing using balloons, quite like Serbanenko, in fact, pushing the balloons into the aneurysm in his day. But the idea here was to make a temporary barrier within the artery to keep the coils in the right place while you were delivering them. So here in the left-hand side, you can see actually kissing balloons, we call them. It's one balloon in each branch, just to keep the coils in the right place while you deliver the coils with a third catheter. Instead of a temporary barrier, some people started using stents borrowed from the cardiologists, and shortly afterwards, in the early 2000s, there were stents designed specifically for the cerebral circulation, and these provided scaffolding across the entrance to the aneurysm to keep the coils in the right place. And this extended the indications for certain aneurysms that had previously been difficult to treat, and improved safety in those aneurysms. Now we have a very wide range of stents with different mesh designs, lengths, diameters, and so on. So for instance, in this patient, this is a top of the basilar artery, pretty wide-necked, horrible thing, which would be difficult to treat with coils alone. This is a so-called Y stenting, so there's a stent with you can just see the tines on it in the left cerebral artery. I hope that's not going to collapse on me. another one in the right posterior cerebral artery, and keeping the cause in the right place and keeping the artery open. The problem with putting metal work into the arterial system is that platelets want to stick to it. So we have to give the patient antiplatelet therapy, usually dual antiplatelets, which is difficult if they've recently had a subarachnoid hemorrhage and may need other interventions such as ventricular drainage. So best avoided if possible in the acute setting. It was noticed quite quickly that patients who had stents put in had a much lesser rate of aneurysm recurrence. And also that if you overlapped stents or used a certain type of braided stent, you could induce stasis within the aneurysm. And that led to the development of flow-diverting stents. This is something that was introduced in the last 10 to 15 years. In the bottom corner here, you can see a normal sort of mesh stent with pretty open cell structure, whereas a flow-diverting stent, I've got one here, is made with a very fine wire filament, which is woven into a material with, if you touch it, it feels like silk, and then a cylinder is created. And the whole idea of a flow-diverting stent is that once you deploy this into the artery, and it decouples blood flow from the artery and the aneurysm. It induces stasis in the aneurysm, gradual thrombosis, the aneurysm shrinks, you get endothelialization across the stent, and eventually the artery remodels. And this increases the rate of aneurysm occlusion and was particularly useful for very large or very wide-necked aneurysms and fusiform aneurysm, one that had been really difficult to treat previously whilst preserving the artery. So here's a large, not quite giant, internal carotid artery in the cavernous sinus, flow-diverting stent, and this is the result at 6 months, where the aneurysm's completely disappeared and the artery is remodeled. And using a similar design with this closed mesh, very fine mesh, instead of placing it in the artery, the new range of devices, the intrasaccular flow disruptors such as Webb, are placed inside the sac, and this mesh faces the circulation. It induces thrombosis in a similar way and avoids the need for antiplatelet therapy. A quick case example. So I haven't cherry-picked this. This is something from last month. A 41-year-old patient collapsed in Lincoln, I think, with a low Glasgow Coma score and prior to intubation and ventilation. CT head showed a large subarachnoid hemorrhage. For those who aren't used to looking at CT scans, the CSF, the fluid in the brain, should be this dark grey. And instead, it's quite white where the CSF should be, and this is the blood. This is quite a large subarachnoid hemorrhage. And a CTA confirms an aneurysm of the anterior communicating artery as the culprit. So the following day, patient comes for embolization. I've placed a guide catheter at the skull base, fed a microcatheter up round the bends to the aneurysm, and used that to deliver a series of soft platinum coil into the aneurysm, so that at the end of the procedure the aneurysm is excluded from the circulation. And we do this virtually every day. I mean, this is something that is extremely common. The patient's still with us about 5 weeks later, and that's mainly because, as often happens when you have a large subarachnoid hemorrhage, it blocks the normal circulation of CSF, and the patients get hydrocephalus, and she's required a VP shunt. But without coiling, she had about a 40% chance of rebleed and probable death. She's alive. She's got no motor deficit, although her cognitive outcome is still uncertain. Okay, that's enough about aneurysms. The other large volume procedure that we do is mechanical thrombectomy for acute stroke. And to understand how it works, I'm going to have to give you a very short tutorial on pathophysiology of stroke, so bear with me. If you block blood supply to the brain, that part of the brain will die very quickly. It only takes about 5 or 6 minutes for the neurons to exhaust their energy source and start to die. If you block the circulation below the circle of Willis, then the circle of Willis will usually take over and the brain will receive enough blood to keep going, usually. If you block the circulation at the level of the circle of Willis or above, then the only way for blood to reach the brain beyond the blockage is through a network of leptomeningeal collateral blood vessels. These are very small, only about 300 microns, and they connect the territories of the anterior, middle, and posterior cerebral arteries that supply the cerebral hemispheres. So in this case, where the left middle cerebral artery is this little short stump, and there should be a lot of blood vessels here, there's just a void. So the only way for blood to get there is up through the anterior cerebral artery, over the surface of the brain, and through these tiny peel collaterals retrogradely down into those branches and almost to the level of the blockage on the other side. Unfortunately, you don't know how good your collateralization is until you have a stroke. There's no way of testing it, and it's not particularly related to how old you are or how healthy you are. It's very individual. People who have bad collaterals, unfortunately, progress their stroke very quickly. Probably within a few minutes, they lose that part of the brain. And it doesn't give us time to, for therapies to reopen the circulation and for that part of the brain to survive. But if you've got good collateral flow, as this patient has, so that there's occlusion of the top of the carotid artery and the middle cerebral artery, which just aren't filling. But if you look further up, the middle cerebral artery branches are filling almost symmetrically with the other side. But whereas these ones are filling orthogradely towards us, these ones are filling retrogradely away from us. This brings a concept of penumbra, where there's almost always a core infarct where the blood supply has been insufficient to keep things going. So you get a core infarct, the little red dot, if you like, on the left-hand image. And around that, there's an area where the brain is receiving not enough blood. The brain cells are dying, but not yet dead. And this is the so-called penumbra, which if you can restore the normal blood supply, that part of the brain is still salvageable. Obviously, with time, the core infarct grows and the penumbra eventually disappears. To reopen the artery, I was very skeptical, I must say, in my early days that this would ever work. But the first device that was used was something called the Mercy retriever, which quite frankly didn't work, and trials showed it didn't work. In 2007, Penumbra came up with a system where we could get a much larger catheter towards the clot and a little agitator which would break it down a bit, and then you'd hoover it up with the catheter. That was the idea. Unfortunately, that didn't work either. It was only in 2012 and afterwards when people started using modifications of stents that were used for aneurysm treatment that you could reliably start to remove clots from occluded arteries. And in 2015, there were a series of articles published in the New England Journal, which proved that this was a very effective treatment. And most of them were based on using the solitaire device, which is what you can see in the bottom right-hand corner. Just a modified stent. I've got one over here again. The aim, of course, of any stroke therapy is to open up the artery again, whether it's intravenous thrombolysis, clot-busting drugs, or mechanical thrombectomy. And the sooner you can do it, the better. Because we want to salvage that ischemic but not yet dead brain, the penumbra. Unfortunately, for the worst kinds of strokes, for instance, blocked internal carotid arteries or the middle cerebral artery, intravenous thrombolysis isn't very effective. But with mechanical thrombectomy, we can open up reliably 85, 90, even 95% of cases. But of course, that doesn't always guarantee a good result clinically. Very briefly, what do we actually do? There are two broad methods of removing clots. One is to get that as large a bore catheter as you can up to the face of the clot in order to hoover it up. Or the other is to go past the clot, open up a stent, and actually drag the clot out, similar to a fishing net. In effect, most of us do a combination of the two. So this is the aspiration part of the equation. We've got a microcatheter up to the clot. We use that to track a much larger catheter up, take the microcatheter out, and then just attach it to a pump. And it comes out and it's in the pump filter. It's as simple as that. The alternative method is to go up past the clot with a microcatheter, bring up a stent in the microcatheter, unsheath the stent. That becomes entangled with the clot, and hopefully, if you pull the stent out, it brings the clot with it. And most of the time, it does. And this is the kind of thing we fish out on a stent or on the end of a suction catheter. Does it work? Well, with intravenous thrombolysis alone, for large vessel occlusions, about 25% of patients will be alive and independent at 90 days, modified Rankin score 0 to 2. With mechanical thrombectomy, about double that number will achieve independence. And overall, the number needed to treat to reduce disability is about 2.5. And just to put that in context, for PCI, coronary acute interventions, depending which outcome you measure, the number needed to treat is somewhere between 10 and 40. So mechanical thrombectomy is an extremely effective treatment. Since the early trials, we've had a lot of advances. So we now know that we can treat slow progressors up to 24 hours, even longer, and they'll still get a significant benefit. We can basilar artery occlusions. We had a lot of trouble proving that they worked. We knew they did, but proving it was more problematic. But now we've got the evidence that it works in a selected group of patients. And in ways that we don't entirely understand, it seems that even patients who present with very large infarcts still benefit from having the artery reopened. It's counterintuitive, but it seems to be the case. Again, I haven't cherry-picked this. This is from last week. A 62-year-old woman who last seen well at 5:30 in the evening, discovered at 6 o'clock, amazingly, got an ambulance and was in hospital within an hour, had a very high stroke score, 24, anything over 5 and we get interested. She had dense hemiparesis, gaze palsy, hemianopia, dysarthria, as you can predict from a right middle cerebral artery occlusion. She had that confirmed by CT, so I've put a little arrow where there's a bright artery. This is the clot in the middle cerebral artery. And I'm sure Adam can see it, but some of you may not be able to detect an acute infarct affecting the corpus striatum and a little bit of the insula. Otherwise, the right middle cerebral artery territory looked good. The CTA also looked pretty good. Here's the occlusion, quite a short occlusion in this case, but there's reasonable filling of the vessels by collateral flow over the surface of the brain. And I've got a little app on my phone called Viz AI, and it tracks all the stroke protocol scans that are done throughout the region and detects it. So the information goes to the cloud, it's analyzed, and if large vessel occlusion is found, it pings my phone and tells me there's a potential MT patient in Lincoln or Derby or Leicester or wherever. And it gives us this immediate readout of the CT perfusion. And in this case, there was a small core infarct, the little red dot in the basal ganglia, and the penumbra is in green. So there's a potentially salvageable brain, which is a very large volume in this case. Without recanalizing this artery, the predicted disability would be severe, permanent left hemiparesis, cognitive impairment, and all that. And because she's a young patient, she might need decompressive hemicraniectomy, the skull lifted off, to cope with the brain swelling that tends to ensue. If you remember, she was found at 6 o'clock. We got an alert on Viz at about 7:30. She got IV thrombolysis immediately afterwards. She came to the angio suite. She had a general anesthetic, needle to the groin at 8:20, mechanical thrombectomy completed within 20 minutes. And this is the before picture. You just can't see the middle cerebral artery. It's not filling at all. And within 20 minutes, restoration of the normal orthograde flow of the middle cerebral artery. CT head the next day. If you remember, her stroke score was 24 when she arrived. It's now dropped to 5. We've got that little core infarct. She's going to do very well. She'll probably make a full recovery. So, we've been a little slow off the mark nationally and locally trying to get a full 24/7 service going. The publications, if you remember, came out in 2015, 2016. At the time, that year, we did 12 cases. We were commissioned to provide a service in 2018, but with no money attached. Thank you very much. So we were expected just to absorb the extra costs and just get on with it. 4 years later, we did 10 times the number, 114 cases, mostly weekday, mostly daytime, because there were only 3 of us. We couldn't cover 24/7. However, there are now 5 of us, and in autumn last year, we went 24/7. Since when the numbers have just gone off the scale, we'll be on course for at least 350 mechanical thrombectomies this year, and probably in the future we'll be looking at 500 or 600 per year. Probably that number, because we're going to be doing the large core infarcts as well. Which brings me neatly on to a very brief discussion about evolution of interventional neuroradiology as a career. I'm delighted to say I got into this small niche area at exactly the right time. Just when things were getting very interesting, things would come along almost, it seemed like every week there was a new device, a new technique, something for us to pick up on. I was the third neuroradiologist when I was appointed, and we did everything. We did all the diagnostics. We did hundreds of cerebral angiograms because there was no non-invasive alternative. And we did about 60, 70 cases of aneurysms, mostly aneurysms a year. Now there are 19 neuroradiologists. 14 of them do all the diagnostic work, well, most of it, and 5 of us do the intervention. We do hardly any cerebral angiograms because it's all done by CT and MRI now. But we do, over 500 interventions, and that's going to go up. It's going to go 700 or 800 interventions overall within a year or two. And it's consultant-led. So if, God forbid, you have a stroke at 2 in the morning, it's going to be me or one of my colleagues, more likely, who is going to be pulling the clot out. So with 5 of us, that's a pretty onerous stretched rota. So we're a bit thin on the ground during the day. We hardly meet each other anymore, which is a shame. We have much fewer interactions with patients than we used to. Patients come in the door, we do our plumbing job, and they go out the door, and we never see them again, which is very different to how it used to be. I used to go up to the ward at least once a day, maybe twice a day, to see patients. Now, once or twice a week, and it's just for specific patients, usually in my elective cases. It's quite a stressful job, things usually go well, but when it goes wrong, it can go really wrong, Patients die, patients have strokes, and with the lack of colleagues being around, the onerous stretched rotas, I really worry for my junior colleagues that they might burn out. It also makes it very challenging to train individuals. We need a lot more INRs, but they don't have angiograms to practice on, if you like, that they used to. It's such a high-risk procedure, most of the stuff that we do, that it's very hard to stand beside somebody who doing it clumsily and slowly, when you could do a better job yourself. It's really hard. It's urgent, it's unpredictable work, so the learning opportunities may be spread out during the day. And to address the lack of INRs nationally, the GMC took about 5 years and a lot of negotiation, particularly with my colleague Rob Lentil, to come up with a credential to allow other doctors to learn what we do. And there are a smattering of neurosurgeons and interventional radiologists, IRs, around the country who are doing this job. It's just not the same job that I got into, and I'm quite happy to be leaving it maybe in a year's time, to be honest. The future, robotics is a possibility. People have already successfully treated aneurysms, done carotid stentings using a device not dissimilar to this. So it becomes, you sit in front of a console rather than a patient and move levers. It's almost like a computer game. The idea being that it's more reproducible, finer movements from the robot than with your hands. But we rely so much on the haptic feedback of the wires and catheters that I can't imagine that a robot can do the same job. But I was a skeptic for a mechanical thrombectomy, so what do I know? There is a potential, of course, if it does work, for remote operating, across the city, across boundaries, even in different continents. So, in conclusion, I hope I've shown you that interventional neuroradiology has undergone a rapid evolution in the 31 years that I've been involved in it. Technology continues to push those boundaries very shortly we will have a very ingenious endovascular device for treating hydrocephalus. The future holds promise for other diseases, and chronic subdural hematomas is the next procedure, that embolization of the middle meningeal artery, which will increase the numbers that we treat significantly in the future. And before I finish, I just want to thank some people. I want to thank a really good bunch of neurosurgeons I've worked with over the years. I want to thank the anaesthetists, some of whom are here, who've worked with us and have been incredible. Excellent radiographers, excellent nurses in the radiology department, and particularly these two guys. Tim, who gave me a job in the first place and was my mentor in the early years, and Rob Lentil, who's been my ever-present colleague for the last 25 years. And I'd also like to thank Carolyn, my wife, who consoles me when things don't always go to plan in the angiotheatre, and without whom I wouldn't have achieved half what I have. Thank you very much.
I'm happy to take one or two questions.
Yeah, definitely.
What a fantastic lecture from Norman. I'd like to think that Tony Mitchell would have been proud to hear that, with his interest in vascular disease and trials and evidence and these magnificent developments.
Thank you.
Norman says he's happy to take one or two questions if anyone has anything they want to ask. Terry.
Well, I'm sorry to be first. One of the big bugbears of subarachnoid hemorrhage is cerebral vasospasm, which for people who don't know is when the subarachnoid hemorrhage, in a way that we still don't really understand, causes the vessels to clamp down. And my question is, do you think in the future, we used papaverine, which was pretty useless in an hour or two, it was back to square one. Do you think in the future, interventional radiology can do something for cerebral vasospasm?
So trials have been proposed for 20 years on doing angioplasty for vasospasm, and it's just never got off the ground. So I think the answer to that is for individual cases, yes, where it is proven to be, patients are proven to be pressure dependent, so you give them hypertension, their neurology improves, you drop the blood pressure again, you know, and in those patients, it's possible that angioplasty will improve the situation, but really there are no trials that prove it, and I don't think there ever will be. John?
Yeah, we're clearly very lucky in Nottingham to have this service provided for the population. Do you know how many other cities in the country have a 24/7, 7 days a week service?
So most of England now, the northeast is still poorly served, and there are corners of the country, so southwest, Kent, Cumbria, not doing so well. Scotland is a disaster, and unfortunately. Northern Ireland's pretty good. Wales, also a disaster. So it's very patchy. But England, most of England, about 90% of the population is now covered with 24/7 services.
David.
Hi, I'm David. I have a vested interest in the MT for acute stroke, having suffered that in 2019. I have little observations and a question. The trials that show equivalent or a benefit of MT, I always wonder whether the endpoints are absolutely the most relevant, being alive and not fully dependent 90 days later. I found that recovering from hemiplegia and then trying to become dependent again was hardest even a few years down the line. I wondered if other engager on sort of later quality of life?
Yeah, so all of the stroke trials were measured in modified Rankin scoring, so which reflects quality of life. The two higher scores being independent for most of daily activities. And I do wonder about the large core infarct trials, because although it shows patient improvement MRS shift up the scale, we're still talking about some patients who might die but still ending up very heavily dependent, or and you wonder, is that the right thing to do? I don't know the answer, but we are, if we do include large core infarct patients in the service, then we are going to create possibly a lot more disability.
Adam.
Thanks, Norman. I think my experience is that most people that come in with a ruptured aneurysm didn't know they had it before they come in. And I know that with incidental aneurysms, the sort of risk stratification models are getting more and more complex all the time in terms of trying to manage predictions about what the risk of an incidentally detected aneurysm rupture is. How far away do you think we are from models or risk prediction models that would allow effective screening with people based on their risk factors, you know, to kind of identify aneurysms prior to rupture? Do you think that's anywhere near, or is it just too heterogeneous?
Yeah, so although, you know, over 5% of the population, adult population, may have an aneurysm, most of those don't need treating. So, and for any screening program, you have to have a good intervention. And I think we don't know who to target. We can't do the whole population. So we know it's related to certain diseases, Ehlers-Danlos syndrome, polycystic kidneys. Sometimes it runs in families, and you can predict that way. But really, there's, apart from those small groups, there's no way of targeting areas of the population to be able to screen them. So currently, the answer is no.
Joe.
Norman, I'm lucky enough to have worked with you in theatre, and you make it sound very routine, navigating your way to these blood clots and navigating your way to these blood vessels and these aneurysms. And, you know, having watched, you know, just literally have a catheter, don't you, and you're twiddling it and you're suddenly finding your way through, and to see that happening on the screen is quite extraordinary. So what particular skill set do you think you need to actually do that?
Oh, you've got to be, you know, you've got to be good with your hands. I mean, but, you know, that aside, I think mostly it's a mental attitude you need, you know. When occasionally things don't go well, you have to be able to cope with that and bounce back quickly enough to be able to deal with the next patient, you know. And so there's a certain there's a certain type of surgical attitude that is required, I'm afraid. You know, you have to have a bit of a thick skin, but you have to care as well, obviously. So it's a fine balance. I mean, I think when I'm training somebody, it's not so much their manual dexterity I'm looking at; it's how they cope under stress and cope with complications, you know. And they're the people I want as colleagues, the characters rather than the skillful guys, you know.
I think Norman's playing down his manual dexterity, I would say, because a few years ago I had a 3-day-old admitted with a subarachnoid hemorrhage with a big blood load and obvious issues, left-sided weakness from it. And I thought, what am I going to do with this? And I spoke to him, and he treated the aneurysm and then said, that's not the youngest one I've ever done. I thought, okay, I'll bear that in mind in future. So, you know, certainly speaking as a neurosurgeon who pre the 1990s would have had to deal with some of these pathologies, or in many cases say, this can't be dealt with. You know, it's been an absolute game changer to have people who can do things inside the blood vessels in people of all ages.
Because
Because children are just small adults.
But it's the same
aren't
for
they,
you. I
Norman?
mean, it comes
is.
routine. You know,
Yep.
you honestly, I hardly think when I'm doing it. It's automatic now. You know, when you, in fact, when you have to start to think, then that's when things go wrong. You know, it's like a golf swing. You know, if you start thinking about it too much, then you know
Must be
the
my
ball
problem.
goes anywhere.
Wayne.
All right.
I don't be too nihilistic about treating people who might be just converted to a very disabled person. I don't know how much you see of the back end of the pathway of the rehabilitation side, but my experience, not specifically from coiling aneurysms and what have you, or revascularizing, but it was in fact the hemispherectomy patients. And some of them neurosurgeons were less than keen on doing it. And this was done in young patients, originally with the cusp of 60, so younger patients. But I asked them, as they've been in 4 months and had, you know, a very significant disability, and having had, you know, a dramatic change in their life. One was a florist that just set up a new business, and then his wife was having to hack on and keep going, and he was kind of 40 or something. And I asked him, was the whole thing worthwhile? You know, be honest. Yeah, and you know, don't be kind. Just tell us. You know, would you rather just have been left? And of the 5 I asked, they all said, yeah, I wanted what I've got. Another patient I saw in Oxford, and I just routinely had to go and it was one of these respite admissions. I discovered I covered them for some reason. I had to go off to another hospital and go and see this, and they said you need to do a research, just sign a DNR form for him. So I took the DNR form, confidently expecting he could barely speak because he was bilateral strokes. He was very nearly tetraplegic. He was totally dependent. And I said, well, I need to ask you this. It's a routine thing, and I put him through the whole thing. Do you want us to call up? Yes, he wanted the arrest team. He valued what he had. And I think that's hard to, you know, when you go to see the back end of the pathway.
Yeah, and I don't. And thankfully, those decisions are made by, you know, people like you. But I hear what you're saying, and probably faced with the same challenges, I'd say the same. I imagine, but I don't know.
Final comment, probably because it's 8:30. Caroline.
Hi, thank you very much. That's fascinating. I was a GP, trained in the mid-1980s. At that point, if somebody had a stroke, the reason for admitting them was if they couldn't cope at home. And you had a first 24 hours, is it going to be a TIA or not? Things have moved on so incredibly rapidly. So my question is, with the facilities that you're now offering and able to offer, how on earth do you educate the ambulance service, the patients, the GPs, that there's this amazing facility out there in order to try and prevent a lot of the disability?
Yes. Ambulance service in particular is a problem for inter-hospital transfers, because you're already, if you're in Lincoln or Derby or Leicester, you're already in a place of safety, and so you do not get the highest rating for inter-hospital transfer from an ambulance, which is very frustrating. So, you know, you saw that little diagram, what happens with time. Your core infarct grows, your penumbra disappears. And sometimes we have to wait for an hour and a half, or even longer for the ambulance to turn up to bring the patient. So that's adding to disability, and it's very hard to, I mean, the ambulance service are really pushed and short of service, but it's so frustrating standing, you know, with the team ready to go, tapping your foot, everything's ready, and there's just no patient, you know, and you wait, and very frustrating. I think it took a while actually for the regional stroke physicians to catch up, but they're there now, probably aided by this little device on my phone, because everyone in the region now knows that I'm looking over their shoulder. If there's a large vessel occlusion in Leicester, I know all about it within a minute. So, you know, I think we are getting virtually all those patients transferred in now.
Is it just your phone, Norman, or is it the on-call phone?
No, I've shared the pain. It's all right with
It makes you
several
feel slightly
colleagues.
better.
Oh yeah, thanks.
We don't have a vote of thanks, but what we do have is I'd like to ask Anne Mitchell to come up and give Norman the Mitchell Medal for for giving this lecture. And again, we'll take a
Just
picture.
before
of
we do
that's
that,
all right.
if anyone wants to come and play with bits of kit at the end, feel free. I'll be standing here.
So there you go. We've got a medal here engraved for Norman on the occasion of tonight's lecture. So,
It's been an honour to do it is a memorial lecture.
and I'll take one with your co-conspirators behind as well. Perfect. I've got them behind you as well.
Thank you very much.
Thank you so much. That's all, folks. Thanks for coming, and we'll see you hopefully next month for Professor Jonathan Corn. Thank you.